Hi, I'm Dr. Warren Low. I'm the consultant urologist. I'm here to give a presentation on the common urological problems seen in men. Now, in order to answer all the questions, I shall now begin my presentation, which touches upon a lot of common urological problem encountered by men. So to begin with, I would like to start off with 3 scenarios. Scenario number 1. A 75-year-old man with a persistent inability to achieve the erection for the past 3 months. He is otherwise healthy with no medical problem, apart from high cholesterol, which is well controlled with the medication. His serum testosterone is normal. He has attempted many medications, but to no avail. He is also exploring other traditional medications, but nothing seems to help. So when you are being confronted with patients like that, what would you do? How would you advise the patient? That would be number 1 scenario. Now, to begin with, I would like to touch upon the first topic, which is erectile dysfunction. Persistent inability to attain and to maintain the erection sufficient to permit the satisfactory intercourse, and that is what we call erectile dysfunction. Now, when the patient have erectile dysfunction, what is exactly the duration for erectile dysfunction? Usually should be more than 3 months. What are the risk factors? Number 1, obesity. Number 2, smoking. Why? Because the nicotine can easily pluck off the blood vessels, which happen to be smallest blood vessels in the body. And hypercholesterolemia, post-radical prostatectomy, heart disease, diabetes, hypertension, because all these things will narrow down the blood vessels. Low testosterone level, spinal cord injury or surgery, and of course, medications also contribute to erectile dysfunction, such as antidepressant, antihistamine, antihypertensive. So, as you know, the penis actually contains small blood vessels. And basically, erectile dysfunction is a warning sign. When you start to get erectile dysfunction, it's basically telling you that your blood vessels down there is already starting to block. And if you don't take it seriously, what's going to happen and what's going to follow will be potentially a heart problem, such as ischemic heart disease or even a stroke, because you know those are the bigger vessels that also can get blocked off at the same time. Now, what are the complications of erectile dysfunction? Low self-esteem, unsatisfactory sex life, stress, anxiety, relationship problem, and of course inability to get the partner pregnant. Now, how do we diagnose a patient to have erectile dysfunction? Number 1, to get a good history. Find out how long has he been having it and how frequent does he have the erectile dysfunction. Also, we need to examine the testicle, examine the penis to find out whether there's any congenital abnormalities, and not forgetting the blood tests such as cholesterol tests or even the blood sugar level to find out whether he has any other underlying medical problem, and the urine test to rule out the urinary tract infection. Now, treatment entails several components. More importantly, you know that there's a big part of erectile dysfunction caused by psychological issues. So counseling, counsel both the man as well as the partner. And then if it doesn't work, and can attempt the medication. But as you can see from the first scenario just now, the patient have attempted many medications, but it doesn't work. So the big point here is that when the medication doesn't work, what else can we do to the patient? Number 1, you can teach the patient how to do self-injection. Number 2, you can even propose something like a penile pump or even penile implant. Not forgetting the fact that you also have to check the serum testosterone level, because if the testosterone level is far too low, you may have to also supplement it with some testosterone in order to build up the confidence and also to improve the erection. Now, you know that the medication, we have many medications in the market. Okay, it is important to actually fall back on the right medication rather than seeking alternative medication, because for those medications which are approved by the FDA, you naturally know that the duration of the medication, when it works, you know, what are the side effects, so we are very much in control of that. But if you were to seek out for alternative medication, what's going to happen is that you probably do not know what's the duration of the medication, how long it takes to work, and what are the side effects. So this can be potentially dangerous to you. We also teach the patient about Cavijet injection. Now, injection is basically injecting certain medications into the penile shaft. It may sound a little bit daunting, but it does work for a lot of patients which medication failed. So for those medication, if you inject it into the penis, will it cause any problem at all? First of all, you got to teach the patient how to do it. Number one, when the patient was first advised on the injection, you got to show him how to do it. You got to titrate the dose, and of course, make sure that the patient is not on any aspirin, warfarin, clopidogrel, any form of a blood thinner, because that can cause massive bruises on the penis. Not forgetting that you need to mention also the side effect of self-injection, because if you have a constant injection over to the penis, what's going to happen? Ultimately, it probably will heal with some form of a fibrosis and scarring, and the penis may turn out to be a little bit harder than the normal. So if the patient has tried out the medication and it doesn't work, so what is the next alternative? You can actually talk about penile pump. So you can see from here, I do have a little penile pump here. Pretty easy to work because you can see that there's a battery down there. So what you need to do is to insert the penis into the penile pump. So it created a negative suction pressure or a vacuum. So in that, the penis will get engorged because the blood will all be drawn into the penis. And after that, you put a ring around the root of the penis, and that is intended to trap the blood in there so the patient remain having the erection. So after the intercourse is done, you can actually remove the ring or the rubber band, and then after that, the patient will go back to flaccidity again. So this is good, but of course, it does give a bit of a pain because you are literally trapping the penis. So it's good for those patients whom the medications or the injection doesn't work. It is an alternative for them as well. Now, ultimately, if everything fails, and if you really want the erection so badly, what do we do? So you can see in my hand, I have something called Penile Implant. So you know that we have two big vessels in the penis. So you can see that these two silicone rods implanted into the penile shaft. Now there is a balloon here, and also there's a pump. Okay, so this pump is going to be placed just in the scrotum between the two testes. Now you can see that the balloon is going to be filled up with salt water or saline. So the moment the patient wants to have an erection, all that he needs to do is to press the pump. So what will happen? The water from this balloon is going to come to this rod and fill up the silicone rod. So when the silicone rod is being filled up, obviously it's going to become very turgid, and that's how the patient achieves the erection. Now, let's say if he have had the intercourse and he's done with it, so how does he achieve the flaccidity? There's another pump down there. So you can see that there are two pumps, one big and one small one. So when he presses the smaller one, all the water from the rod is going to go back to this balloon, and then this whole thing will become flaccid, and that's when he goes back to normal. So what are the measures that you can do for yourself? Now, first of all, lose weight if you're obese, quit smoking, and then regular exercise, and if you have drug problem, please seek help for that. Number two scenario, a 60-year-old man with a history of prostate cancer presented to us with urinary leak after the prostate cancer surgery. So he was given various medication by various doctors, and he was advised on the physiotherapy, which he tried, but nothing seemed to help. So we wet about 8 pads a day. To him, it's a big distress. He also presented with recurrent urinary tract infection. He wishes to remain active in his social circle, but now he's helpless about his situation and he's shunned away from the social circle. So, this patient, is there any way that we can make him dry and treat his problem? So we shall now move on to the second topic, which is urinary incontinence. And that ties in with my scenario number 2 and number 3. Now, how many types of urinary incontinence that we have? We actually have many types, but we broadly categorize them into 4 types. The first one is urge urinary incontinence. The second one is stress urinary incontinence. And the third one is a blend of both stress and urge incontinence. And the last one is overflow incontinence. Now, what do you mean by stress urinary incontinence? Stress urinary incontinence is not mental stress. Basically, when you exert yourself, when you carry heavy things, when you cough, when you laugh, when you giggle, especially in women, very often they encounter urinary incontinence. But what about men? Do they also encounter similar situation? Yes, they will, but in several scenarios that I'm going to outline later. Now, the second one is urge incontinence. What do you mean by urge incontinence? Basically, it's a wet, overactive bladder. You know that whenever we encounter overactive bladder, we feel the need to rush to the toilet the moment the thoughts of going to the toilet or even the thoughts of going, to pass urine just run through our mind. We have to rush to the toilet. If we don't make it in time to the toilet, we start to have this urine leak, and this is what we call overactive bladder with urine leak or urge incontinence. Now, in fact, the most common type, especially for women, is a blend of both urge as well as stress incontinence. So these contribute to the third type of urinary incontinence. And the last urinary incontinence is overflow incontinence. That means to say that either the patient has some form of a bladder outlet obstruction, for example, a big prostate or bladder stone which is obstructing the outlet, or the patient have an underactive bladder. The bladder is not contracting. So when the bladder is not contracting, the urine is just pulled in the bladder, and ultimately it's going to become overflow and spill, and this is what we call overflow leak. So now, is it important for us to differentiate the different types of leak? The answer is yes. The reason is because for urge incontinence, you can treat them with medication, whereas for stress incontinence, no medication, obviously, because it's a weakening of the sphincter or even the pelvic floor muscle. So in that way, there are other alternatives that we have to tell the patient. So no incontinence are alike. So please don't treat the patients with just any other medication. Importantly, you have to differentiate different types of incontinence first. So now, men and women are quite different because women have a bladder followed by a urethra, which is usually about 2 to 5 centimeters. So obviously you know that the urethra is pretty short and is held together by the pelvic floor muscle. So if the patient have multiple deliveries, instrumental deliveries, like for example vacuum or forceps deliveries, or even multiple abdominal surgery, hysterectomy, oophorectomy, all these things can eventually lead to some form of a nerve damage and causes them to have stress incontinence in a pre-existing short urethra. Now for men, our urethra, which is the urinary passage after the bladder, contribute to about 20 centimeter. The exposure may be about 4 to 5 centimeter, but there's another 15 centimeter in there. So with this long convoluted passage, it's difficult for us to experience stress incontinence. But we can actually have urge incontinence. Okay, like for example, we rush to the toilet the moment we think that we need to go to the toilet. So the anatomy difference does play a part in terms of the urinary incontinence. Now, what are the problems that is associated with urinary incontinence? Obviously, the patient will have low self-esteem, social withdrawal, depression, sexual dysfunction. Just imagine halfway through the intercourse you start to leak. That's pretty embarrassing, isn't it? And it's also posed as a burden for caregiver. Sleep disturbance, especially when you have to get up many times to pass urine, ulcers, UTI, sepsis. Now, how do we investigate those patients with urinary incontinence? Number 1, get a good history. Number 2, a physical examination. Number 3, to find out whether the patient have urine infection. So urine test is mandatory. Do an ultrasound to find out whether the kidney is fine, whether the bladder is okay, whether there are any stone associated with it, whether the patient have a big prostate. And sometimes we may even put a camera in just to rule out the bladder outflow obstruction to identify whether there's anything like, for example, bladder cancer that contribute to this urgency and frequency. Okay? And of course, ultimately, if we cannot really differentiate which type of incontinence, because you know that the patient can present to you with a blend of all types of incontinence, then we have to do something called urodynamic or bladder function study to differentiate these different types of urinary incontinence. So stress incontinence, as I mentioned earlier on, most of the time is because of a heavy exertion that is exerting onto the pelvic floor muscle. So several risk factors are, for example, those patients with chronic cough, constipation, weight lifting, and those patients who are pretty obese. Now, men seldom encounter stress urinary incontinence, but when they do have stress incontinence, usually it's because of some intervention. For example, after prostate surgery, it can be a surgery for benign prostate enlargement. It can also be a surgery for prostate cancer. Sometimes when we undergo major abdominal or pelvic surgery, even in men, colorectal surgery, the nerves can get damaged and we may actually end up with incontinence as well. Not to mention if the patient do encounter problems like trauma to the pelvis, resulted in pelvic bone fracture, that obviously will disrupt the whole anatomy and the patient will end up with stress urinary incontinence. Now, what are the treatment for stress urinary incontinence? As I mentioned earlier on, stress urinary incontinence is not something that you can use medication to treat. The first thing that you would advise the patient to do is probably to send him for physiotherapy. find out whether the pelvic floor exercise or the biofeedback, gives some improvement to the patient, because you will not tell the patient to straight away go for surgery. Now, if the patient have had several months of physiotherapy to no avail, there's no improvement at all. For men, you can certainly think about male sling. So you can see that over here, I have something like a sling. Yeah, so this is what we call a male sling. So imagine your bladder is like this, and there's a urethra, and everything is held on together by the pelvic floor muscle. And if you do have a stress incontinence, when you cough, it starts to open up like that. So that's the reason why you leak. So what you want to do is to bring it back to its original position, and all these things can be done and held back together by this mesh. To be honest with you, this mesh, you can see that it's pretty flimsy, and it's just a mesh. It holds no water. So once we put it inside there, the patient is advised not to carry heavy things, not to exert himself too much, because his body tissue is going to grow into this mesh, and eventually it forms scars. So for the next few months, the patient is advised to stay, normal activity is fine, but nothing too exertive. So when the scars start to form, and it will actually give the strength, and the patient may not end up with stress incontinence anymore. So this is one way. And this is usually meant for those patients who have not so bad urinary incontinence. For example, wetting about 3-4 pads, 5 pads maybe. Yeah. So for those patients who literally leak like a tap, is there anything that you could advocate? Yes, there's something called artificial urinary sphincter. So you can see that over here, I have another gadget, work pretty much the same as the penile implant. Number one, you can see there's a tiny balloon which we will implant it into the abdomen. Number two, you can see that we have a little pump here. Number three, you can see that we have a cuff. So what we do is that you can imagine that this cuff is going to be encircling the urinary passage. Okay, it's going to be encircling the urinary passage. Now the cuff at all time is filled with salt water. Okay, so as usual, this pump will be placed in the scrotum between the two testicles. So at all time, the patient is dry. So when he wants to pass urine, what he does is that he just has to press the pump, which is situated in the scrotum. And then what happens is that the water, which is encircling the urethra and which is inside the cuff, is going to be channeled back to the balloon. So when this water is channeling back to the balloon, this cuff opens up, so the patient will pass urine. So this is how it works. So I repeat again. So you can see that this is a cuff. And if you were to zoom in a little bit, you can see that the water is filling up the cuff. Okay, so the water is nothing but salt water. And this whole thing is encircling the urethra. So it's at all time keeping the urethra closed. And that's the reason why the patient is dry. So when the patient wants to pass urine, all that he needs to do is to press the pump, and the water from here is going to be channeled to the balloon, which we place inside the abdomen. So when the water from the cuff is channeled back, it opens up. So when it opens up, the patient passes urine. 1 or 2 minutes later, the water from the balloon is going to go gradually back to fill up the cuff. So when the cuff is refilled again with salt water, what will happen is that it closes off the urethra and the patient will remain dry again. So pretty simple, but it's actually meant for those patients who have very, very bad incontinence. Now, is there any other thing that we could advocate? Yes, for those patients who are not fit to go for haircut, we can actually certainly inject something around the urethra, and this is what we call a bulking agent. So bulking agent is a chemical material that we can actually inject into around the bladder neck area to approximate it a little bit, and this one can be done under local anesthesia. It's usually meant for those patients who are really not fit to go for surgery, and that would sort of like give them some improvement in terms of urine leak, but it's not, of course, all that ideal. And so this is all about the stress urinary incontinence, one type. Coming to the second type of incontinence, which is an urge incontinence. Now, when the patient have urge incontinence, what do you mean by urge incontinence? You know that our bladder can accommodate about 400 ml of urine. So once we finish passing urine, it should leave behind 0. Okay? And then the first time that we feel the presence of urine is at least about 150 ml onwards. So when you have 150 ml of urine in the bladder, the signal will be triggered, and it will send the signal up to the brain, and the brain will then send another signal down telling you that you have some urine in the bladder, and if you want to go to the toilet, it's fine. But if you want to hold up to about 400 ml, which is the maximum capacity, then it's okay as well. But the first time you feel the urine, the presence of urine is at least about 150 mils onwards. But for those patients with so-called overactive bladder, they do not need to wait until about 150 mils. They just have 30 mils, 50 mils in there. They already feel it because the signal, the sensor in the bladder is prematurely sent up to the brain. The brain will then process it and send another signal down and telling the patient, okay, you should go to a toilet, you should go to a toilet. So this type of patient always go to a toilet many times. But unfortunately, they just pass very little urine. 30 mils, 50 mils, 30 mils. So in normal circumstances, you should not be feeling the urine, but these type of people, they already go to a toilet many times and pass very little urine. So this is what we call overactive bladder. So for this type of patient, how do we go about treating it? Most of the time, we would actually give the medication. So this incontinence is a type of incontinence that we can use medication to treat as opposed to the previous one that you can't use medication to treat. So this one, the medication aims to relax the bladder. So when the bladder gets relaxed, it can store a little bit more and the patient can hold the bladder a little bit longer before he has or she has to go and visit the toilet. So medication is the second line. And the first line is physiotherapy. It does work to a certain extent. And if the medication doesn't work, what can we do? Now, goes down to Botox. We all know about Botox. Botox is used extensively in aesthetic surgery. For example, those patients who have wrinkles, and what do? They inject the Botox in there. So it's like half paralyzing the muscle, and then after that, the muscle will get flattened out and the wrinkle will disappear. Likewise, you can apply the same principle onto the bladder. So when the patient have overactive bladder, what you can do, you can just put a needle in, of course via the scope, injecting into the bladder, and that will kind of like half paralyze the bladder. So for those patients with a lot of overactivity, resulted in urge incontinence or urine leak. So when you inject it, which takes about 5 minutes the most, and then the bladder will go into a half paralyzed state, and that the patient can store a lot more urine rather than visiting the toilet every 5-10 minutes. So Botox is one way to go. Now, if the Botox fail, what are the things that we can do? Now, again, it's very important for you to actually go back to find out what is the history of the patient first. Because number one, you need to rule out whether the patient had Parkinsonism, strokes, or other things. If the patient has neurological disorders, you may want to identify those neurological orders first. Number two, also find out whether the patient is fond of taking caffeinated product like, tea, coffee, carbonated product like Coca-Cola, Pepsi-Cola, citrus drinks, or even alcohol, because all these beverages is going to stimulate the bladder and cause a lot of overactivity. So if you are a person with unknown neurological cause end up with a lot of overactive bladder symptoms, just ask yourself and see whether you actually are taking all those beverages that stimulate the bladder contractility, because that will definitely lead to overactive bladder. Okay, so now as I mentioned earlier on, treatment, medication failed, go to Botox, and if the Botox failed, what else can we give? We can talk about percutaneous tibial nerve stimulation. You must understand that this is a procedure done as an office-based procedure. That means to say that the patient comes just for about half an hour, and all that you need to do is to identify the nerve, which is usually situated at the posterior tibial nerve near the ankle there. And once you apply the stimulant in there, so the electrical impulse will be actually sent to the nerves that supply the bladder, and then after that, it's almost like an acupuncture, right? This only takes about half an hour, but it has to be consistently doing the same thing for the next 3 months or 12 weeks. So after that, the effect from the literature can last up to about 3 years. So it's not too bad a deal, because this is obviously just an acupuncture. It's not a general anesthesia, it's not done under local anesthesia, and the needle is extremely fine. This is what we call PTNS. Now, if this one failed, what do we have? We have another one called bladder pacemaker. We know what is a pacemaker. Pacemaker is usually placed in the heart to rhythmize the contractility of the heart. But you can also place it down to the bladder. The good thing about it is that it works on two extreme ends. One is a severe overactive bladder, whereby you have tried everything from the medication to the Botox to the acupuncture and nothing works. Then it actually helps to bring down the contractility. So go back to normal. And the other extreme end is bladder failure. So we know that at this moment, there's no medication to stimulate the bladder. So those patients who cannot pass urine because of bladder failure will end up using a catheter or a urine tube with a back, okay, to pass the urine. So this bladder pacemaker works on two extreme ends. It can stimulate the bladder, which fails, and also kind of like bring down the contractility of those patients who have severe overactive bladder. So this is what we call interstim. Now, for those patients who have overflow incontinence or overflow leak, that means to say that either the patient have a bladder outflow obstruction, such as big prostate or bladder stone, please find out what the reason is. If it's because of big bladder stone, take out the bladder stones. If it's because of a big prostate, sort it out with either medication or even surgery. Now, we also have to identify and see whether the patient have an underlying underactive bladder. For example, those patients who suffer from diabetes. So their bladder is not contracting like a normal person, and then in that way, it's like half bladder failure. So what we can do is that we can actually propose them to have an intermittent self-catheterization or even catheter, because if they don't do it, the residual urine will eventually become a source of infection for them, and you will end up with recurrent urinary tract infection and sepsis. Also identify and see whether the patient have underlying other medical problems, such as the one that I mentioned earlier on, neurological issues, or even patients who are on certain medications. So what are the medications that can cause bladder failure? Number 1, antihistamine. Number 2, antipsychiatry, antidepressants, sleeping pills, anti-asthmatic, anti-allergy, flu tablet. All this medication relaxes the bladder too much, and sometimes the patient fails to pass urine because of those medications. So you have to actually rule that out. And of course, there's another group which are the patients that are born to be like that, so congenital abnormalities. So for those patients who have overflow incontinence, what do we do? As I told you earlier on, there's no medication in the world that can make the bladder contract. So either you put a catheter in, or you actually have to teach the patient how to do intermittent self-catheterization. Now, as I mentioned earlier on, the InterStim or the bladder pacemaker works on 2 extreme ends. One is for severe overactive bladder, and the other one is for bladder failure. So this is another alternative that you can actually advise the patient. Okay, failure of which you probably have to tell the patient that they may end up with incontinence that will require them to change their pad very often. Take care of the soaking pads, and of course the skin care. Make sure that they don't end up with all sorts of skin infections, such as bacterial infection, fungal infection, and skin excoriation, and etc. Coming to the scenario 3. A 65-year-old man with a mild Parkinson's disease present to you with frequent urinary tract infection and urine leak. On examination, he was found to have a big prostate. He was then given the prostate medication. Symptom seems to relieve slightly, but the urine seems to continue to leak. His post-void residual urine is within a normal limit. He was then given the medication for presumed overactive bladder, but the patient claimed that there was completely no improvement at all. So when you are being confronted with a patient with urine leak and medication doesn't seem to help, is there anything that you can do to make his life more bearable? So coming to my next topic, which is benign prostate hyperplasia or BPH. So prostate gland enlargement is common as man gets older, and prostate enlargement can of course cause very bothersome urinary symptoms. And the untreated prostate gland can certainly cause bladder and also kidney damage. Now, what do you mean by that? So you must understand that the prostate itself basically holds not much of a function except providing a little bit of lubrication when you ejaculate. But it is an organ that we need to pay importance to, because prostate cancer is something that, in about 2018, from the global scan, in Malaysia alone, we have about 1,700 cases of prostate cancer, and out of which 890 patients died. So it's not so much about the prostate cancer, it's because of the poor awareness, because of the poor public education. What happens is that a lot of patients are not aware that they have prostate cancer, and the moment they come with symptoms, it's actually far too late. So let's touch upon the prostate enlargement now. So what are the prostate symptoms that usually will make the patient come to us? Frequency, urgency, nocturia or passing urine many times at night, intermittency, and then incomplete emptying of the bladder, weak stream, they got to strain a lot, and of course it does affect their quality of life. So we group all these things into a scoring system called International Prostate Symptom Score. So now from there, we can roughly gauge whether the patient have mild, moderate, or severe symptoms. So what are the risk factors that patients have prostate enlargement? Well, prostate is an ever-growing organ, and it's because of aging, and of course those patients with a strong family history of early prostate enlargement, they probably have encountered prostate enlargement earlier in life, and of course the changes of balance in the male hormone, this contribute to the prostate enlargement. So what are the complications that you may encounter with prostate enlargement? The most common one is, of course, urinary tract infection, acute urinary retention, bladder damage, because you must understand your bladder can hold up to about 400 mils, and with a lot of urine stay put in there because you're not able to empty, what's going to happen is that this residual urine will certainly become a source of infection, and with a lot of pressure exerting all over the place in the bladder, eventually will result in bladder damage. If the bladder cannot hold on to so much of a pressure, what will happen is that the pressure will go back up there and it start to destroy your kidney. Okay? And of course, if you have an obstruction down there, your bladder has to try very hard to push the urine out. So inadvertently it's turning itself into overactive bladder as well. So that's why some men with a big prostate actually present to you with urgency and frequency. Okay? So now, how do we diagnose a big prostate? From the history itself, the symptom that I've just suggested, do a prostate examination. The importance of getting a prostate examination is because not just that you want to find out whether the patient have a big prostate, to also find out whether the prostate is nodular, irregular, or even hard, suggestive of prostate cancer. We usually will do a flow study to identify whether the patient have a very good flow and pass urine within a certain limited time, or take a long time to emptying the bladder. So this is a Euroflow. And after that, we do a bladder scan to find out whether the patient have a lot of residual. As I mentioned earlier on, 0 to 50 is normal. If the patient end up with about 200 mils of urine, it's literally telling you that he only passed about half the urine and left another half inside the bladder. And that, of course, will be a perfect recipe for him to get recurrent infection. Also, you need to get some blood tests to find out whether the kidney is damaged. So the blood test is kidney the function test. And of course, lastly, the PSA, which is a prostate cancer tumor marker, to find out whether the patient also have a possibility of a prostate cancer. Get a urine test to rule out the urinary tract infection. And lastly, if we need to, put a camera in to find out whether there's any other thing apart from this big prostate. Are we talking about a bladder stones? Are we talking about a bladder cancer which is sitting there at the bladder outlet? Okay? And of course, ultrasound to assess the kidney and see whether the kidney is enlarged or whether the kidney is damaged. Now, what are the differential diagnoses when the patient presented to you with so many types of symptoms? Number one, you have to find out whether this patient is suffering from urinary tract infection. Number two, whether there's any bladder stone. Number three, whether there's any neurological disorder leading to neurogenic bladder. Number four, whether the patient has prostatitis apart from big prostate alone. And number five, whether the patient have a urethral stricture, narrowing of the passage. Because if the patient have a narrow passage, the treatment is not to give the prostate medication. You've got to sort out the narrow passage. So now, what are the common treatments that we give for patients with a big prostate? Number one will be an alpha blocker. Well, what it does is that it actually relaxes the lumen so that the patient can pass urine a bit better, but not forgetting the fact that you have to pre-warn the patient about the side effect, which of course is a postural hypotension. So especially in elderly men who's taking the prostate medication, please make sure that they know that when they get up and they change their position, they have to do it very slowly. Otherwise, they will experience some form of dizziness. It will be a good thing to actually check the patient's blood pressure first and make sure that the patient's not having a borderline blood pressure, because if you were to bring the pressure so slightly down, what's going to happen is that he will experience the dizziness. Now, the second medication will be something to shrink the prostate gland. You know that the prostate is an ever-growing organ, so you need to give the medication to shrink it if the first medication doesn't work. But the shrinkage of the prostate takes a long time, take a couple of months. So most of the time when the patient starts to experience some difficulties, despite the fact that he's on the first medication, then you may have to add on the second medication before it goes into retention. Okay, but the second medication is what we call 5-alpha reductase, can often give the patient erectile dysfunction, and make sure that you tell the patient much beforehand. So if the medication has been taken and combined medication doesn't work for the patient, what is the next step? Then you have the advanced surgery. So we talk about the TURP. TURP can come in the form of either a normal conventional TURP or even laser. All right, both are equally good. It depends upon the indication. All right, and of course, for those patients who are not fit to go for any form of surgery, either spinal or general anesthesia, you have something called a prostatic stent. You can see here. So prostatic stent is actually deployed under local anesthesia. It's only taking a few minutes. So what you do is that you put this at the end of the scope, and after that, you actually slowly cut yourself into the prostate area, infuse some hot water. This whole thing is going to get expanded because it works on the temperature principle. And after that, it just push open the prostate gland. So the patient will be able to pass urine after that. but make sure that the patient doesn't have underlying bladder failure, because the whole process of passing urine involves a concerto effort between bladder contraction and prostate relaxation. So there's no point opening up the prostate, but the bladder fails to contract. So ultimately, the patient is still not able to pass urine. Okay? But the stent, of course, is good, but it's not perfect, because it does have its complications, such as number one, the whole thing can get encrusted if the patient have issues with stone in the past. Number two is obviously it's a foreign body, a risk of infection is there, bleeding is there, and of course sometimes it can get migrated as well. So the fourth topic that we're going to talk about is urinary stones. So you know that urinary stones can form anywhere. You can see that we have kidneys, we have ureter, and of course we have the bladder here. So what are the kidney stones? They are basically hard deposits in the kidney, consist of mineral and salt. So when the urine is concentrated, the mineral kind of get crystallized, stick together, and it ultimately forms stones. So the stones can decide to stay within the kidney itself, or it can actually come out. So most of the time we say that small stones, the patient may not even experience any symptom at all, it just passes on its own without you even doing anything. But the bigger stones, sometimes when it sits inside the kidney, it does give you some discomfort, especially when you get dehydrated, because the kidney will be rubbing onto the stones and give you some ever so slight discomfort and occasionally passing blood in the urine. But if the stone decides to get propelled down, follow the urine, get stuck in the ureter, and this is where you get very severe excruciating pain together with bloody urine, which of course occasionally may be just microscopic and you're not seeing it in the urine. But the pain will be radiating from the back coming to the front. So when the patient does present to you with symptoms of urinary stone, think about the loin pain present to you with bloody urine as well. And occasionally, the patient may present to you with fever, because obviously all the old urine which is stagnated in the kidney that cannot be drained eventually will become a source of infection. Now, sometimes the stone can get thrown down into the bladder, and the moment it passes the distal ureter, most of the time it will just come out on its own. But we do have occasions whereby the bladder stones start to form in the bladder. Why is it so? It's because when you have a big prostate, what happens is that the urine is not empty from the bladder completely. So there's always some residual urine in there. So the residual urine is going to stay put in there, and eventually urine is nothing but salt and mineral. It's going to crystallize and form stones. And that's how the bladder stone is formed together with the big prostate. So the patient have humongous prostate. Don't forget that the patient may also have underlying bladder stone as well. So now, how do we know whether the patient has stones? Patient will present to you with pain. If the stone is stuck near the bladder outlet, the patient will present to you with difficulty in passing urine, blood in the urine, not surprising, because as the stone travels down, it also causes friction along the way. Cloudy color urine, because the urine stagnated in the kidney that cannot be drained out, will eventually become a source of infection. Sometimes the patient will tell you that they pass sandy particles, burning sensation suggestive of infection. And if the patient has systemic symptoms like urosepsis, the patient will present to you with fevers, chills, rigors, nausea, vomiting, very general symptoms. Now we have many types of stone. The common one is of course the calcium stone, followed by the uric acid. We also can have strobite stone. Essentially it's an infective stone, and we can have congenital abnormalities with the metabolite disorders that can result in the cystine stones. And of course, we also can have stones formed from medication. For example, indinavir, which is of course a HIV medication, can also itself lead to stone formation. Now, what are the risk factors? There are some patients who actually have very strong family history of forming stones. So those are the patients that you need to watch out for. And of course, the diet. You remember the high purine diet actually do contribute to stones, and that is of course the uric acid stone that we are talking about. So if you don't take care of your diet, you are very fond of taking red meat, the beef, the lamb, taking the seafood, and of course the beans, the nuts, the tea, all these things can produce high purine and ultimately leads to uric acid high in the level, high uric acid level in the body, leads to gouty arthritis and also urinary stone. If the patient are very fond of taking salty diet, it's also a risk factor. Dehydrated patient, risk factor. Now, of course, there are some other underlying medical problems, like for example, patients with a hyperparathyroidism, renal tubular acidosis, some congenital metabolic disorders such as cystinuria. All these patients actually have a high risk of getting the stone. Some medication, as I mentioned to you earlier on, like cancer drugs or even the HIV drugs, can also lead to stone formation. And of course, you have chronic urinary tract infection that can also lead to stone. Now, how do we diagnose it? Apart from the history, physical examination, get a blood test, get a urine test, rule out infection, see whether there's any blood presence in the urine. Now, you can do an X-ray, but you must remember that X-ray is for you to pick up the calcium stones, and you have other stones such as uric acid, cystinuria, and all this. These are the stones that cannot be picked up from the X-rays because you cannot imagine seeing acidic stones in the X-ray. So X-ray is not 100%. Now, what about the ultrasound? Ultrasound is good in the sense that it is not radioactive, but the bad thing about it is it is not good at picking up very tiny stones in the kidney. And of course, there's a big component of ureter here that you cannot use the ultrasound to pick up unless it's grossly dilated. And the gold standard for diagnosing a stone is actually a CT scan. Now, for those patients who have a recurrent stone formation, please do a stone analysis because you know that they will have stones over and over again. So now, how do we treat stones? Will the medication work? Well, there are two types of medication that we usually suggest to the patient. That one is called medical expulsive therapy. You imagine if a stone which is stuck near the distal ureter, sometimes what you can do is that you give them medication to open up the distal ureter a little bit, and for all you know, small little stones can actually come out on its own. But it doesn't work for all patients because you know why? If the stone is impacted in the distal ureter for the longest period of time, what's going to happen is that the surrounding wall will also get swollen and it will form like a cushion holding the small little stones in place. So not all stones will come up with this medication. So the medication may or may not work, but usually works for smaller stones. So when your patient is on medication, please remember that the medication only works for about a month. So a month later, the patient would have to go for another CT scan to ascertain that there is no more presence of stone, because sometimes the patient is asymptomatic. Sometimes the stone is stuck there and the damage is ongoing and the patient is symptomless because he's been taking a lot of painkiller, but it doesn't mean that the stone has passed. So after a couple of years later, when you do an ultrasound or CT scan, you suddenly find out the patient has non-functioning kidney, and the patient said that I have no symptoms, but maybe a couple of years ago I have one episode of pain. So the patient loses the kidney just like that. So very important for you to know about the medical expulsive therapy, and also the other thing is medical dissolution therapy. What is medical dissolution therapy? Because we know that sometimes the uric acid do contribute to stone formation, high uric acid. So if you give medication to dissolve the uric acid, sometimes the stone can get melted off. But the problem is that, do you think that the stone is just by uric acid or calcium alone? Probably not, because it's usually a blend of everything. So you may dissolve the uric acid part of it, but the rest of it are still there. So the stone is probably still there. Okay? And of course, we do have isolated cases whereby the whole big stone is actually nothing but uric acid. So with the medication, it certainly can melt the whole big stone. So that is medical dissolution therapy. Now, what about the shock wave? Shock wave is good. Shock wave is not surgery. Shock wave can be done under local anesthesia unless you're talking about children or pediatric group where you have to put them under general anesthesia because they move quite a bit. But the problem with the shock wave is that you can never gauge how long it takes to break the stone, because if we're talking about very, very hard stones, it may need a couple of sessions, and sometimes even after a couple of sessions also the stone may not actually break. Okay? And also the ESWL, or the extracorporeal shock wave lithotripsy, is only meant for stone of certain sizes. Too small stones, you may not be able to heat it. Too big stones, all the stone fragment is going to get dropped down into the ureter and block the whole ureter. So it's only meant for stones which usually is about 5 mm onwards up to about 20 cm. So anything below, it may not work, because when the stone is inside the kidney, when you breathe up and down, the stone moves up and down, and then the ESWL or the shock wave may not be focusing on the stone. Okay, so that is extracorporeal shock wave lithotripsy. And if the patient does have a very huge stone, so what we do is that you know that this is a kidney. So if you have a huge stone there, we can actually discuss about the PCNL. What we do is that we literally just put a puncture into the kidney, because when you're looking at very huge stone, it's impossible for us to put a camera in from below to actually use a laser to fragment it, because it will take ages. So what we do is that we puncture directly into the kidney. So when we puncture directly into the kidney, we can fragment it with an ultrasound. And ultimately, when when all the stone particles are in pieces, we can use a suction or a vacuum to suck them all out, so that there's no pieces that will fall into the ureter and block the ureter. So this is what we call PCNL. Now, for stones which are resistant to the ESWL, means you have sent the patient for blasting a couple of times, but then it doesn't work. So what you can do, smaller stones, you can put a camera all the way up there and pick them up or fragment it with the laser. So this is what we call RIRS. So it's a different type of managing stones in the kidney. So depending upon the stone. So when the patient have a ureteric stone, means to say that the stone is actually stuck in the ureter. So what you can do is that you can put a camera in there and blast it with a laser, and ultimately you may have to tell the patient that they need to have a stent in there because the place where the stone is lodged can cause some inflammation. So when you use a laser to fragment the stone, sometimes the surrounding inflammation can still obstruct the urine flow and the patient may not be able to have a smooth flow of urine through the ureter. So the stent usually will be removed after 1 or 2 weeks. Now, for those patients who have big bladder stones, you may have to consider doing an open surgery to remove the bladder stones. If the patient have a small bladder stones, you can put a camera up, then after that fragment it with an ultrasound or even a laser, and then you can remove them in pieces. All right? What other things that we can do if you have stones? Knowing the fact that you can have recurrence of stone, lifestyle modification obviously, drink more water, avoid stone promoting food, as I mentioned earlier on to you, the red meat, the nuts, the soy, the potato, the tea, the chocolate. Choose the diet which is low in animal protein. And of course, if you think that you have stones, please come and seek help rather than waiting for too long, because sometimes when it starts to become obstructed, the patient will end up with kidney damage and of course, recurrent infection. Okay, so the last topic is blood in the urine. This is what we call haematuria. Again, it can be divided into microscopic or macroscopic. So what is microscopic? Means you never see the blood in the urine, but it's actually there in the urine test, in the urine analysis. But macroscopic or gross is something that you literally see with your eyes, either come off as blood clot, fresh blood, or even pink color urine. Now, there's also an element of pseudohematuria. It appears to be red, but it could be related to the food that you take or even the medication that you take. And for example, red dragon fruit sometimes can give you blood in the urine, so-called blood in the urine, but they are not exactly blood. So how do you find out? Get a urine test, as simple as that. So what are the causes for those patients that present to us with blood in the urine? Number one, the one that we are most fearful about is of course a urinary tract cancer. So you know that anything that comes from kidney, from the bladder, from the ureter, or even from the prostate can present to you with blood in the urine. And the second commonest cause is still stone. Okay, as I mentioned earlier on to you, stone when it travels down, it can cause a lot of friction to the urinary system, and that will lead to blood in the urine. For those patients who have a huge prostate, if they were to strain to pass urine, that also can lead to blood in the urine. For those patients who have a urethral stricture, a very narrow passage, when they can't pass urine, they are trying to force the urine out, they can actually cause some bloody urine as well. Strenuous exercise, postmenopausal woman also can lead to patient presenting with blood in the urine. Some patients are on certain medications, for example, aspirin, warfarin, clopidogrel, any form of a blood thinner can result in blood in the urine. So you can see that the list goes on and on and on and on. So it's important for us to identify what are the common ones and deal with it accordingly. Now, coming to kidney cancer, one of the commonest cause of blood in the urine. Kidney cancer is usually pretty silent, and sometimes they may or may not present with blood in the urine. No, it's good to actually go for an ultrasound. Why? Because body checkup sometimes can actually consist of ultrasound, because since it's so silent, it's a silent killer. So if you don't use an ultrasound to pick up the kidney cancer, you may never know it, because it is not something that you can pick up from the urine test, because sometimes the blood may not even show up. And even if you were to send the urine for cytology, for malignant cells, sometimes it may not show up, because when the cancer cell is not shedding into the urine, you will not see any cancer cells in the urine. And of course, for those silent killer like a kidney cancer, there's no tumor marker, there's no blood test for you to check. So the only way to find out is actually from the ultrasound. And if you have a strong family history, and of course you do have history of chronic smoking, and of course dealing with a lot of chemical stuff or stay beside a chemical factory, and have a high index of suspicions that you could be having that. Of course, other cancers such as bladder cancers and also prostate cancers are equally important as well. So as I mentioned earlier on to you, the prostate cancer, most of the time we have to end up doing a blood test such as PSA and do a digital rectal examinations, mean the examinations of the prostate, to find out whether there's anything more that we need to actually focus on and to investigate further. Now, bladder cancer, flat cancer, sometimes you can miss from the ultrasound or even a CT scan. So sometimes we have to put a camera in to actually find out whether the patient has bladder cancer. So again, as I told you before that, urine may be blood, may not be blood. So it may be important to have a combination of few investigative tools to find out whether the patient have cancer or not. Now, for bladder cancer, what do? We do surgery. Okay, for superficial cancer, we can just put a camera in, we can resect it accordingly. For a huge muscle invasive cancer, we have to remove the whole bladder. Now for kidney cancer, again, depending upon the size of the cancer, if the cancer is small, we can actually just remove partially. We can do it either open, laparoscopic, or even robotic. And of course, robotic nowadays is probably the thing to do because it actually gives about 10 times magnification with a lot of precision, 3D vision, so give you a lot of clear definition of how much you should take. Okay, so it is important to have that kind of a precision when we deal with partial kidney removal. And if the kidney cancer is very big, then we may have to remove the whole kidney. Now, for those patients with the prostate cancer, again, depending upon whether this is a confirmed cancer or not, blood tests and also the finger examination or the digital rectal examination of the prostate cancer, examination of the prostate may not be sufficient, and ultimately, we have to confirm it with an MRI and of course a biopsy. Now, once the prostate cancer is confirmed, depending upon the stage of the prostate cancer, if it's locally confined, talk about surgery, remove the whole thing, it would be the best treatment. And if you're talking about the cancer which has gone outside a little bit or locally advanced cancer, you may have to consider radiotherapy combined with hormonal therapy. And if the patient have the cancer that have gone into the bloodstream, and this prostate cancer usually have a predilection towards the bone, in that case, you may have to consider hormonal therapy or even chemotherapy. Now, so blood in the urine really boils down to the cause of it. If it's because of blood thinner, stop the blood thinner for the time being. If it's because of a big prostate, solve the big prostate problem with medication or even surgery. If it's because of cancer, deal with it accordingly depending upon the type of cancer. And if it is due to an infection, you can easily treat them with antibiotics. And if it's because of a urethral stricture, then deal with it surgically. So importantly is to identify the history, get a proper history, and do the various investigation, and ultimately come up with a diagnosis and deal with them separately. Thank you.